It's my pleasure and privilege to present the India section of our commission on behalf of my co-authors, and I have no conflicts to declare. I think in terms of what I'll be presenting today, first of all, I'd like to give you some background statistics in regard to India, which really sets the scene for the three areas that we've identified: affordability, healthcare, workers' availability, and social cultural factors, which we believe are the areas that require attention if we are to improve cancer care delivery in India, and then also give you a little bit of information as to what governmental and local policies have been begun to improve this. So as we've spoken about before, India is the second most populated country in the world, and it's of interest that it accounts for about 18% of the world's population, but only occupies 2% of the world land surface area. Noteworthy in comparison to China, 70% of the Indian population reside in rural regions, and this has major implications in terms of improving cancer care delivery. I'll just bear this map for you in terms of something I'll be presenting to you later on, but you can see that the most densely populated areas of India are in central and northern parts. And when you actually look at the population density, current results would suggest that about 360 odd Indian per square metre occupy the land density. You can see how that compares to Malaysia, and then you can see how that compares to Australia, where we have a small population but a vast geography. Some basic demographics, I think, which is very relevant to our discussion about cancer care delivery, is that, as Paul has mentioned, the median age of the Indian population is amazingly low at 26.5 years, and this compares to somewhat median age of about 41 years in the US and about 37 in the UK. Gender ratio is approximately 1:1 for females to males. And interestingly, the current expected lifespan for males are at 66 years and 69 for females. And this compares at a quite lower level to Malaysia, USA, and Australia. The literacy rate, which is defined as the ability to understand, write a small summary of your own personal experience, is said to be only about 82% in males and 65% in females, and this compares to approximately 98% in Australia and about 93% in Malaysia. In terms of healthcare, as been mentioned before, approximately 3.9% of GDP is spent on healthcare, with less than 1% directly spent on cancer care delivery. And it's of interest that the components of that is largely from the individual rather than from governmental sources. In terms of healthcare provisions, there is less than one physician per 1,000 and less than one bed per 1,000. And again, I've given you some comparable figures for the US and the UK. I think some relevant cancer statistics that sets the scene. In terms of age-adjusted incidence of cancers, in India there appears to be a higher incidence in females. Oral cavities are listed as one of the most common cancers in both gender types, with breast and cervical cancer being the other common cancers in females. As has been mentioned before, about 40% of cancers are attributable to tobacco, and this impacts on some of the endeavours that have been undertaken. In terms of cancer-related mortality, it's currently suspected that just over 500,000 cancer-related deaths occur in India per year. And there are differences in that the majority of these cancers occur in young-aged individuals, and obviously this has impact in terms of productivity and the workforce. There's also a difference in cancer mortality when looking at education, where lower educated Indian individuals have more than twice the risk of dying. Further, although the age-adjusted mortality rates are similar between rural and urban areas in India, the actual incidence of cancers in rural areas are much lower. So again, reflecting perhaps a lower level of care delivery in rural areas. So first of all, in terms of looking at affordability, just a comparison with some of the other nations around the world, with India only at 3.9%, with a major contribution from household, And this is particularly relevant given that about a third of the Indian population are regarded as living below the poverty line. And currently this is defined as existing on less than $1.50 US dollars a day. In terms of socioeconomic distribution, it's thought that about 15% of the Indian population are regarded as the upper class, and as such are thought that this group are able to afford standard of care cancer delivery, whilst more than 50% of the population are regarded in the poor socioeconomic group. So looking at one of the ways that one can take into account the financial constraints that India faces, clearly primary prevention may well be a cost-effective approach. So taking the area of smoking, you can see that in India there is a six-fold higher smoking prevalence in adult males compared to females, but even in the young population of 13 to 15, a significant number of males and females are smokers. I found it interesting that when you look at this statistic for Malaysia, there is a much higher rate of smoking in adult Malaysians and a very significantly lower rate of smoking in females. Highlight this against Australia and Germany, where there are proportionally higher numbers of females that are smoking. And as a consequence of this, India adopted the Cigarette and Other Tobacco Products Act in 2003, this being a global policy for many nations to adopt, which take aboard those 6 listed endpoints to try and reduce tobacco abuse. Other areas in terms of cancer strategies is really trying to identify the most cost-effective approach for those cancers which are highly prevalent. We've talked a little bit about the use of screening mammography in the 50 to 70-year age group, but also the role of clinical examination has been highlighted in one publication which has shown that it is possible in a model of prediction that it may be able to reduce breast cancer mortality by about 23%, which is very similar to the same model predicting the use of biannual mammography, but at a much, much lesser cost. Cervical screening using acetic acid visual inspection, which is a technique that can be taught to qualified medical assistants, which doesn't require perhaps the same level of training as a medical personnel, has value, as well as identifying early stage breast cancer and cervical cancer for effective treatment is likely to translate to improved mortality rates. In terms of cancer costs, this is just one prospective study that was published in 2011 from New Delhi, where they looked at 430-odd patients who presented to a tertiary referral centre, where these patients either had head and neck, breast or cervical cancer, and really looked at the amount of money that was spent over that 12 months. Interestingly, 40% of the overall cost was actually spent by the patient prior to even being seen at the hospital, with about a quarter of the cost being spent on radiation therapy. At that same time in this study, they evaluated what the monthly income was for the patient seen in that area. And so subsequently, when you compare this to the cost spent for these patients receiving cancer care, it amounts to 170% of their annual income. Another area in terms of affordability is drug therapy cost. And before 2005, there wasn't a need for drug patents to be adopted in India, which perhaps was advantageous in that that meant a number of companies could develop generics. But with the introduction of drug patents in 2005, legislation actually had to be altered in India to allow less stringency of these drugs so that still generic drugs could be made available. And as such, they've actually been shown to win a number of lawsuits against some of the bigger international pharmaceutical companies. Having said that, the highly prevalent use of generics, it has been suggested that it may have a major impact in terms of investment into clinical trial research for these therapeutics. In terms of healthcare workers, just firstly to define the types of healthcare providers that are found in India. So apart from traditionally trained doctors, there is a large group of Ayush practitioners I've listed some of the subsets of that, and for instance, the Ayurveda yoga practitioners have a belief that health is related to not just physiological ill health, but can also be impacted on by mental and personality issues, and therefore the treatment of cancer is seen from those three perspectives. There are large numbers of community health workers. There are a number of registered medical practitioners who have not actually been trained in the conventional sense, and a large number of traditional medical practitioners and allied health workers. When you look at the distribution and the qualifications of the healthcare workers, it has been suggested that about 2.2 million healthcare workers are present in India. However, when you adjust this for qualifications based on education, as well as the residency of these healthcare providers, the ratio drops from 20 per 10,000 Indians down to 11.9, which falls well below the WHO benchmark, which suggests that populations should have at least 25 per 10,000 population to be adequate. And just as a stark contrast in terms of cancer care delivery, the ratio in India is 1 to 16,000 as compared to the USA, which is 1 to 100. It is currently suspected that there are more than 14,000 shortages in terms of primary care providers and specialists throughout India, and a very significant disparity in terms of healthcare providers between rural and urban areas, given that 70% of the population actually lives in the rural regions. So just bring you back to that same population density map that you've been shown before. And of interest, in the southern part of India, which accounts for probably just below the most densely populated parts of the country, this has the highest health standards seen anywhere in India, yet only accounts for 9% of the population, again highlighting the disparity of treatment delivery. Some of the reasons that have been suggested by a number of authors for the imbalance between the city and rural regions are clearly the lower socioeconomic environment in the rural regions, making it much less attractive for trained cancer specialists and other medical practitioners to work in the rural regions. There is actually a disparity in terms of governmental funding for setting up public hospital infrastructure in the country. There are very few patients in the rural regions who have private health insurance, which has subsequent impact in terms of reimbursement for specialists who work in those regions. There's a relative isolation for medical junior staff, such that there is very little continuing medical education, making it a very less attractive place to work, particularly for specialist trainees. In terms of other impact, which is perhaps a little bit more unique to India, that there is quite a significant international immigration of trained Indian cancer specialists. And it's noteworthy that in the US, UK, Canada, and Australia, between 2 to 11% of our trained medical workforce actually come from India. A further disparity in the healthcare workers is that there's very low female representation, and this clearly has impact in terms of female malignancies, and therefore may have further impacts in terms of patients presenting for screening and ongoing treatment. And then lastly, the social cultural barriers, which are again fairly unique to India. There is a significant social stigma associated with the diagnosis of cancer, where anecdotally it is thought to be a condition that is self-induced. One small study interviewed 550 participants, and over 50% of those that were surveyed adamantly believed that they contributed to their own cancer diagnosis. There is significant inequality in females and elderly patients receiving adequate cancer care, and this clearly leads to delay in diagnosis. And up to 50% of breast cancers in India present at a late or metastatic stage. This also similarly occurs for other solid tumours, where in one study up to 80% of solid tumours presented at a delayed stage compared to 15% in the United Kingdom. In terms of education and literacy rate, this has also been suggested to impact on delays in treatment, with one study looking at locally advanced breast cancer. And this education deficiency also impacts on incorrect beliefs, with one study suggesting that women failed to present for cervical screening because of a strong belief that the actual inspection and instrumentation would actually lead to cancer development. It is a patriarchal society with a heavy influence of male approval for females and elderly patients to receive adequate care. And again, this is much more likely to occur for people living in rural regions than urban regions. And then traditional medicine plays a large role in the medical care delivered in India, with 250,000 registered homeopathic medical practitioners, and many of those have been shown that the effectiveness of their treatments are really akin to those achieved with the placebo effect. And then more traditional, akin to those seen in China, where many of the population believe that chants and various sacred powders are sufficient to manage serious conditions such as cancer. So just to highlight in the next two slides some strategies and innovations that have been proposed by the Indian government and local governmental policymakers. So firstly, the importance of actually identifying what the cancer incidence is. And so the Cancer Atlas has been supported by the India Council of Medical Research. A number of initiatives have been adopted by the Cancer Control Program, including major impact on education programs for primary prevention, improving screening techniques for those cancers where earlier stage disease detection will impact on mortality, improving diagnostic facilities. I think one thing that I haven't spent a lot of time on, but again, clearly in nations where a significant proportion of the cancer population present at late stage disease, the establishment of adequate palliative care, both delivery in the home and in institutions, are of absolute importance. And to address the large population density, I think one very potentially effective approach is to look at telemedicine. And so this has been developed, having developed regional cancer centres throughout the country, which then form the basis of specialist telemedicine consultation. And again, collecting adequate data to actually reflect what the country's need is obviously very important. I think it's very notable that a significant amount of money has been tailored towards non-communicable disease focus, which is clearly now taking over from previous communicable diseases as the major cause of death in India. A number of funding initiatives have been undertaken, both locally and nationally, as well as a number of incentives to try and improve undergraduate training schemes, which will then lead the medical practitioners to remain in India and perhaps to have a greater desire to move into the rural regions where this is clearly needed. The other initiative is also training non-medically trained staff to take on some of the easier education programs, as well as some easy screening methodology. So I think just to finish, I think the future direction for India, as it is for the other two countries, is to have good data collection, which is accurate and representative for the whole nation. Clearly, there has to be governmental public policies looking at prioritising areas of need and also identifying priorities which are achievable in the next 10 to 20 years. I think focus on prevention in terms of lifestyle, dietary, tobacco use is clearly important. And I think something which is probably not being evaluated clearly is looking at research which is specific for the Indian population, which allows the results of those research to be interpretable and to be therefore effective within that own country. And then lastly, just to say that equity of care clearly must be a major dominant driving force if cancer care in India is to be improved. And on that note, I'll finish. Thank you.